Hey, good afternoon, everybody. I think Bill Withers is done. My name is Christine Apple. I'm one of the co-chairs of the Milwaukee Mental Health Task Force. I am here with Mary Neubauer, Montreal Queen, Nicole Damiano, and Sally, of course, and we will start the meeting. I just had the ground rules for the meeting, and I left them here, so I'll take them again. Please share any questions or tech issues in the chat. We will monitor the chat and do our best to be responsive. Please remain muted to minimize background noise for others. Auto captioning is provided. You may turn captioning on or off. Click on the caret symbol next to the CC Live transcript button if you want to hide subtitles or to view the full transcript. At the top of your video screen, you can choose between speaker view or gallery view, whichever you prefer. We hope to have time after each speaker for a few questions. To virtual participants, please use the chat feature to type your questions. In-person participants, raise your hand. We'll answer as many questions as we can. We'll try to ask the questions from virtual participants first. Sign language interpreters are provided at this meeting. If you need assistance, access the interpreters, please put your request in the chat. Speakers, please say your name before you speak to help with accessibility. Okay, without further ado, we want to welcome Tarsha Wiggins. Tarsha Wiggins is a Milwaukee-based licensed clinical social worker and has more than a decade of experience in behavioral health. She is a certified alcohol and drug counselor and is the founder of Speak Wellness Behavioral Health Consulting. Tarsha created a form of therapy she coined as trap therapy. The group sessions she leads use energy, music, and evidence-based practices to educate and empower individuals to engage in their emotional wellness. So everyone, please welcome Tarsha Wiggins as I try to put this in the.
Good afternoon. How was everyone today?
Great.
Awesome. I'm going to do my best to try to stay planted right here, but I'm a walker and a talker. So how far can I go before you guys will be back in?
We'll let you know.
Let me know. And I know I want to make sure I'm not blocking people. So maybe I'll stand on this side. First, let me say thank you for having me and thank you for engaging and hearing all that I have to share today. I'm going to try to stay within my time and get through as many questions as we can. All right. Next slide. I get a little Vanna White moment too. Right? Next slide.
We're gonna pull this up in one moment. Well,
Tech is on our side today. Yes, it is. All right, well, we got one slide going while she sets the rest up. So I'm going to spend a little time today talking to you about something called trap therapy, a solution to the emerging mental health needs of our communities. Like the lovely lady before me, my name is Tarsha. I'm going to tell you a little bit about me. She did a really great brief job. I am a licensed clinical social worker with over 14 years of experience in the field of behavioral health. I'm also a certified alcohol and drug counselor. What really shaped and molded how I got to this place in my life is I've been very fortunate to work in every level of care. And I say that now as a badge of honor, but boy, when I was in those different levels of care, it was tough. I've worked in as an inpatient social worker, partial hospitalization programs, intensive outpatient programs, one-on-one therapy. Also had the great privilege of working with a lot of our larger mental health organizations here in the great city of Milwaukee. And also had some time over at Milwaukee County, working as some of their admin coordinators, making sure that the work that they were doing was equitable and they were doing all the things they said they were going to do it within the time frame they said they were going to do it. But last but not least, and what I take most pride in saying is I started out my career as a child protective social worker. Now, those of you that have been in that area, you know that you see a little bit of everything, and that's really what prompted my passion for mental health, my passion for understanding substance use disorders better. So I share all that to say that I am certified, educated, and highly skilled in hands-on application of all that I'm going to talk to you about today. For those of you that know, it's one thing to have a clinical understanding of how to employ evidence-based treatment modalities, but it's another, how do I have motivational interviewing with a parent, with a customer, with a client, as I remove children from your care? That's very difficult. So stay with me. Let's talk about how we get to do some of that stuff. Next slide. So over my years and in the height of the pandemic, I was like most of you, probably sitting at home thinking like, oh my gosh, where are we going back to work? What is this going to look like? What's next? What's next? Worry, worry, worry. And what ultimately happened for me is that I found myself sitting on my porch one day, again, a lot of grace and gratitude there that I had a porch that I had the privilege of sitting out on with my 3 children at home, homeschooling, working from home all day. And I was so anxious and I was so on edge. And I had a moment of reflection. And I said, the only thing that's separating me from people that look like me, talk like me, walk like me, live like me is that I have the understanding to know that what I'm going through is I'm anxious, I'm worried, I'm not sleeping well. And I wanted to do something about that. So what I created is something called trap therapy. Trap therapy is very much what it sounds like. It's the use of urban hip hop music, also known as trap music, to engage people in conversations around their emotional wellness. How many of you, don't raise your hands, just make good eye contact, has had a night or two out on the town? You got through that exam, you cranked out that 25-page paper just in the nick of time, and you had a moment of celebration, right? That's exactly the energy that we have at Trap Therapy. We use hip hop, urban, energetic, invigorating music to engage people around conversations and things that they're very uncomfortable talking about. And we do that in such a way where it's like, well, how do you start off with like party vibes? You get in here, you do the treatment modality stuff, and then you leave with a good snot cry, and the life is forever changed. Let me tell you how we do it. Next slide, please.
Sounds like a night out on the town.
It is. All right. It's coming once I have it. All righty. So first thing first, how did we get to this place? Where is this really birthed in? As I shared earlier, really wanting to make sure that I was attentive to the specific needs of individuals within the BIPOC community, people that look like me, talk like me, similar experiences, right? So first thing first is I had to look at what are some of the barriers? Where is that stigma rooted in within the BIPOC community in relation to mental health? Data here shares that when we look at where those deficits, I recall being a child and early on is that we don't have the luxury of being depressed. You don't have the luxury of being tired or anxious. And before we can really delve in and do work around mental health and emotional wellness, we have to talk about this notion that it's a luxury. That's not a us problem, that's an other people problem. So we have to be honest with that. And we have to understand that anytime we go in as clinicians, is that we have to do an assessment, a biopsychosocial assessment. I want to know a little bit about everything. I want to get a good, full understanding of the symptomology. When did it start? What does it look like? How does it present in your everyday? And we can't delve in and doing work that's specific to our BIPOC community members without acknowledging that this is very much rooted and what they're bringing to the table, what they're bringing with them. So that starts here. We go on and we do a little more research, and the American Psychiatric Association in 2017 showed that roughly 1 in 3 individuals that have a mental health condition, they're having a struggle in life, only 1 in 3 will seek treatment. Why is that? We get the notion that this is what's going on. Why is it that people are not presenting for help? Why is that? Let's go to the next slide and take a look. Mental health by numbers in 2022, 1 in 6 US youth aged 6 to 17 experience a mental health disorder each year. We know, just if you're in this room, you're committed to the cause, you're involved, we know that these numbers have increased drastically, right? According to the Center of Disease and Control, in 2020, suicide was the second leading cause of death for people ages 10 through 14. And I think we can't only just focus on suicide. What else is happening with our young people? What else is also very prevalent in our communities? ADHD, 9.8% of individuals between the ages of 3 and 17 were diagnosed with this condition or this mental health diagnosed with ADHD between 2016 and 2019. anxiety 9.4%, behavioral problems 8.9%, depression 4.4%, right? So we see that the pandemic, mental health, emotional wellness, these two things got together and it's just increasing, all right? Let's see what else there is to share. Next slide. So as we continue on, we'll see that our youth suicide rates are up, our mental health conditions or diagnoses are up. And then we want to come back again and say, what's going on, what's specific in the BIPOC community? In the Ring the Alarm, it really examines suicide of young individual Black youth. The suicide death rate for Black youth rose from 2.55 per 100,000 in 2007 up to 2.48. Black suicide death rate increased faster than any other ethnic or racial group in America. I was really intentional about making sure we included data that reflected this because the first slide started by, we don't have the luxury. We don't have the time. I hear in families, I hear in conversation with our community members that she just needs to stop being lazy and get up. That's not language that we encourage, but that's where it's embedded. This is what our young people, our young adults, this is what they're living in, this is what they're hearing. So doesn't that make it challenging for them to say, yes, I'm struggling with something? We have to understand that. It also goes on to show here that the suicide rate for Black girls and women ages 10 to 24 increased more than 30% in 2020, and by 23% among Black boys and men in that same age group. So we have a problem here, right? We have some work to do in this area. We want to be a support. Next slide. Little suspense makes it exciting, right? It's all by design. So how do we get to trap therapy? Let's talk more to that because trap therapy is a solution. We are a solution to the emerging mental health needs. How do we do that? How are we a help? I want to be your problem solver. I want to help you. There's a great TV show I got a little wrapped up in Netflix. And the coin of the show is, how can I help? I was like, boy, if someone was asking me that, like, how can I help do those dishes? How can I help take them to the store? How can I help pick up my kids, right? And I started watching the show and I was like, gosh, I want to be that for someone else. I want to be that in the field of mental health. How can I help? How can I meet your unique need? How can I be a change maker forever, right? My hope is that trap therapy is that, and we're that because we do all these wonderful things. We don't just come with great music and an invigorating conversation, but we are going to employ evidence-based treatment modalities. We're doing the stuff that we know works. What are those modalities? We're using the strengths model. We're employing motivational interviewing. How can I partner with you? Would it be okay if we took some time to talk? We're doing those things. We're harnessing that resiliency. What things have you overcome before? What helped you then that can help you now? We're doing those things. We're also employing cognitive behavioral therapy. What you think is what you believe is what you go make happen. I get the privilege of working with a group of young ladies every Monday night. And they've taken it and they got a whole little dance they do with it. I was like, this is my like Michael Jackson moment, right? It comes off nice and it gives a smile, but I'm like, what are you making come happen? What are you doing with those thoughts? How do we catch those thoughts? How do we modify the behavior into the things that you want it to be? And these are our young people. Talking in very simplistic terms about evidence-based treatment modalities. Other things that we, of course, do at Trap Therapy is we use music to employ those conversations, to change and shift our neurochemicals in our body, right? We're doing that stuff. Let's get the dopamine going. Let's get the serotonin going. Let's release and get that stuff going so that we can engage in this conversation. All right, next slide. This would what I wanted to do here is not give you a lot of conversation around this is what trap therapy is, this is what trap therapy is, but we're not able to share these videos with you today. So I will further explain what it is. So we're very intentional about not just once you're there, but we also build that anticipation. It's 2024. How are we going to engage our young people? Social media. So I'm very intentional around our social media following, our engagement. Things come across with high energy, fun, whatever trending music and dances that are in style for the moment. But our goal is that we leave you with a mental health, a wellness tip. Last summer we started I'm not sure how many of you may have heard that it was by Cardi B, but it was a song called Tap In. And it's like tap, tap, tap in. And it was, you probably heard it at the Super Bowl at this point, right? But we took that. We take those things that are trending and popular and we pair it with mental health. So we did an entire series called Tap In Tuesdays where we tap into your mental health, debunking myths, looking at stereotypes, stigma, all of those things, so that we can come in and have some conversation around that's a myth, this is what's true. This is a false misconception. Let's talk about where is that rooted, right? So this was just an example of how we utilize those platforms to have those conversations, because how many of you just rush out, you see it one time and you go buy it in the store? None of us. You got to see it a couple times. Lots of times, right? So that's exactly what we're doing with our social media following. I'm enticing you, enticing you, enticing you. And along the way, I'm educating you, educating you, and educating you. How can I partner with you? How do I build trust? In our clinical world, we call that I'm building rapport. I'm consistent, I follow through, and I'm engaging. That's what we do. Next slide. All right. This clip here was going to share with you just some of the specifics around when we have that following and we're engaging on our social media platforms. What does that look like? We did a Wellness Wednesday series where really encouraging people to embrace their emotional wellness, engaging in the services and treatment providers. So in this clip, I talk about how you are so special, right? So I gave the analogy here that, baby, you're special. See, you're so special, you only see specialists. So when your teeth hurts, you see the dentist. If your eyes are bothering you, you see the optometrist. See, you're so special, if your foot hurts, you see the podiatrist. So when your mind, your heart, or your emotions are heavy, remember, you're special. You only see specialists. So how about see the psychologist? How about we tap in to a therapist? And some of us may need to talk to the psychiatrist. So we do things like that that are upbeat, engaging, and really planting those seeds of embracing your emotional wellness, engaging with providers, talking about the things that feel heavy does not make you fill in the blank. Because a lot of our members in our BIPOC community, we're still carrying that negative connotation of language that's stigmatizing. You're crazy, you're weird. And then we have our elders and we have people that are caring for you in some instances, using language or saying things that are demeaning. You just need to stop being lazy. I don't understand how what do you have to worry about? It's hard to embrace young people and have conversations around things like that when that's what their environment is fostering. So we try to build a platform and a following where we are chopping away at that every day. You're not crazy. This doesn't make you crazy. It doesn't make you weak. It doesn't make you weird. In fact, it shows how resilient you are. It shows how much of a risk taker you are, how courageous you are, how well you are, that you're getting your needs met. I believe that is my time. I thank you all so much for hearing me today and embracing trap therapy. I'll open it up for questions if that's okay. Awesome. Oh, I'm sorry, I didn't see you. Go right ahead.
How do I become engaged?
I was hoping someone was going to ask that question. So we have a lot of opportunities for you to do that. First and foremost, our goal is that we want to be easily accessible, and a part of being easily accessible means that it is free to you. So we have a youth edition that is held every fourth Thursday at the Sherman Phoenix off of 33rd and Fond du Lac. Every fourth Thursday is free, open to the community. Doors open at 5 if you want a good seat and some hot chicken wings, because they always have something great for the young people to eat. Get there at about 5. We start our session at 5:30. We go 5:30 to 7. We've had phenomenal engagement with young people in the community. We have group homes bringing their youth out as well. So that's one way that you can engage. I also share that we just don't stop at trap therapy. We also, in youth version, we also have a community version where we say, hey, what we learned is that once the young people got there, their parents stuck around. Oh my gosh, 2 for 1. This is the best deal ever. So we acknowledge that, hey, there's some conversations that's really geared towards adults, or there's some things that we may want to dig into that might not be appropriate for young people to be a part of at the same time. So we have a community version as well. We partners with large community organizations to make that happen. Our last one was at G's Clippers, where we moved those barber chairs right on out the way and set up a big platform so that we can engage. We also host worship and therapy sessions because everybody is, not so loving of the trap music at times. So we offer a different iteration of music to embrace our believers as well. And we're doing the same thing, using that music to guide conversations around our emotional wellness. For those of you that are happily married and want to stay that way, we have a couples editions too, where we embrace similar style music, education, application in all of our sessions. Last but not least, how to stay engaged. I'm on social media platforms, TikTok, Instagram, and Facebook. The handle is Speak Wellness. All right, any other questions?
You've got the microphone.
Oh.
You were gonna ask.
And I don't know if I can get out this shot. Don't get me in trouble.
Got one.
They won't let me come back.
I've got one online that I'll ask.
Okay.
Martina Gallon Graves asks, how do we contact you to partner for a community session?
Absolutely. First of all, thank you, Tina. I appreciate you. Certainly feel free to reach out to me at any of those media platforms that I mentioned, Facebook or Instagram at Speak Wellness. I also will leave my contact information here for if anyone wants to reach out to me via email as well, just so that's a bit easier to have that conversation.
Phenomenal presentation. Are there other forms of music? Like if I wanted to do a rock and trap therapy, how do we incorporate something like that?
Absolutely. We do use different genres of music. One of the things that makes music therapy effective is that this is why brace yourselves. It has to be music that's of your palate, right? So if you are a country girl, if you are a rock and roll, I can catch up with you. All right. But we do offer different genres of music so that we can engage and have those conversations for sure. Any other questions?
How old are you working, the kids? I mean, what age are you working with?
That's a great question. Thank you for asking that. So we work with youth as young as 3 upwards. So at our youth sessions on Thursdays at Sherman Phoenix, we break our session. So the way it's structured is I'll do some psychoeducation, some application, and then we'll break out in smaller groups so that we can do an application portion that's age appropriate. Usually we'll have our groups typically run about 5 up until the age of 11, and then we'll do an older breakout session with our teens, because what I found is that the teens don't want to always do what the littles are doing, but then when they see how cool their project was at the end, they're like, oh man, why we didn't do that, Miss T? And I'm like, I didn't think you wanted to color today, but we can next time. So yeah.
We have a 3-part question online from Leon Cannon. He wants to know, what will growth look like for trap therapy? What are services you wish you were able to provide that you may not have the finances to do? And how many kids are you serving per year?
Oh, that's a great question. I'll start in reverse order. Last year, we serviced over 500 youth in the city of Milwaukee. I know, I was excited about that. Okay. Impacted youth and adults in Milwaukee. So we were very excited about that. Services I wish that we could provide, I would say more trap therapy. We would like to be able to bring this to schools. We would like to bring this to other organizations that have impact with youth. And we really, really are moving in the direction of we don't want to just service youth because there's this wild thing. Lean in, guys. Let me tell you a secret. There's this wild thing that's happening. People send their youth or the young people, but guess where they go when they leave? Home. And guess who didn't come? Home. So we work with youth, we create change within youth, and then they go back home to the first slide. We can't do that. We have to impact adults. We have to impact families. And that's what we want to do. And that will be our expansion in 2024. And then the first question, I lost the first question. The first part of the 3-part.
What does growth look like for trap therapy?
Oh, okay. That was it. I got all 3. Perfect. I didn't want to leave any out. Any other questions or comments?
A quick question.
Yes.
Wonderful
The
session
microphone for our online audience.
Thank you. My question is, how do you see this being implemented more in schools? You mentioned that you wish you could do more in schools. Then the other question I have is just in terms of, you mentioned that this is based on several evidence-based practices. So what do you envision in terms of creating your own sort of body of evidence research?
Absolutely. So whenever I get that second part of the question, I'm like, it was a great look. It was a struggle to get a B in statistics. Okay, I'm just gonna just tell y'all what happened. So I always get a little like, oh, but our goal is, and we do understand that we have to build data. We have to collect data. We're capturing our data at every session so that we can start being able to account. And what we're really moving toward is we want to measure something called distance, which is when our youth leave corrections, when our youth leave our sessions, how do we measure that change in their community and in their lives? So we are putting some things in place so that we can start to engage that better. But ultimately, we will love a partnership. We will love some collaboration with some of our universities that say, hey, this is something new that we like to work together and say, hey, this is working. And it is. You know, when you know something but other people don't know yet, that's where we are with it. And how I would like to see this being incorporated in schools more is we understand that most schools have a significant deficit when it comes to being able to provide mental health services. Our services are provided in a group format. So if we would like to be at different schools utilizing or doing large group-based work. Our largest and our largest group trap therapy session was 114 people in a room. I was a little tired after that one because what I like to do is I have other clinicians that help with breakout sessions, but I like to engage people one-on-one. I will work a room, which I'm like, this was hard to stay still today. Any other questions?
Oh, I'd like to just say thank you so much for this presentation. I personally engaged in dance and movement therapy about 10 years ago to do trauma work. And I did it one-on-one. And I can tell you that it was the most important work I've done in the 40 years of my recovery, to be able to do movement and to be able to incorporate music of every variety of genre, and to have a therapist that was trained in internal family systems. And because I came up from a really screwed up family and generations of messed up systems, trauma. And wow,
Yeah.
you are phenomenal. Thank you.
Thank you. Thank you. Thank you so much. Anyone else?
Can you tell us your website online and how to get in contact?
Oh, absolutely. Sometimes I'm a talker, guys. I don't know if you know, I will talk and I will sell and we will be friends. And I'm like, well, let me just tone it down today. Let me be nice. They won't invite me back. But yes, you can connect with me at www.speakwellness, BH, that's B as in behavioral, H as in health.com. All right.
Do you have any literature anything that has that information on it? that you
Absolutely. I
brought?
did bring some items with me today that I certainly can share with you all of those that would like that today. Absolutely. See, I was trying not to I was about to set up a whole little workshop session on me. I was like, I got 20 minutes. I better not do too much. I will also like to say publicly that I have done a more extensive training around trap therapy. I'm a two-time presenter at the National Association of Social Workers, where I've presented and gone really in detail around research, our evidence-based treatment modalities, and why we put these things together the way in which we've done them. So if you guys are interested in that, I would love to come back and go into much more detail around what that looks like.
You.
Tarsha, I just have one more comment. This is Nicole. I work for Independence First, so we're always thinking about accessibility. And we would love to talk to you about how to make that accessible to all folks who may not respond to the music part of it, but may be able to engage in other ways. I'm so stoked about having you here. I'm very excited to meet you. We have lots of contacts in the mental health task force that we would love to get you to as far as schools and universities. And we're going to put those PhD students to work and get this actually written down and put into paper. I would ask, so as a white woman, I fostered two boys who were Black, and it was very hard for us to talk about mental health with them, not because we had a challenge talking about mental health. We're very open in our family, but their family of origin had a really hard time with understanding that. And so I'm curious, how do I, as a white woman, bridge that gap and help get more folks involved?
When you say bridge that gap, I want to make sure I'm understanding the question. How do you bridge that gap to get more people involved to support them? Or how do you bridge the gap to encourage them to embrace and be an active participant in the conversation?
Yeah. So I'm gonna wait for the mic. Okay, so I think for me, it's what I think about is that the people that look like me have done a lot of harm to folks who don't look like me. And so how do I help to bridge that gap to help people connect to safe spaces, to help them understand how mental health treatment, therapists, social workers can be helpful?
Yeah. I have a lot of thoughts around that. I think the best thing that you can do is to continue to be genuine in your conversations and to be an advocate and an ally. It's that, it's that notion of, I can show you better than I can teach you. Let me show you what that looks like. Let me show you what kindness is. Let me show you compassion. Let me show you what it means to maintain and uphold your word. Let me show you what no judgment looks like. And I think that by people observing that and seeing that people trust, and then people buy in, and then people believe. Yeah. Any other comments or questions? In a minute, they're gonna get the Sandman out and like holidays and scooch me out of here. Awesome, there's a question here in the back. Mike is coming. He said just throw it.
Is on, yes. My name is Pete Knesny. I'm on the steering committee of the task force. And I was interested in your background, mentioning you'd done work in the child welfare system. And we did our Karen Avery forum a couple of years ago, maybe 2022, maybe 21, on concerning the child welfare system and trying to raise up peer advocacy for parents threatened with this awesome power of the state to take children away from parents, and also the racial disparities and implications. And that's an issue I think is very important to the community and to the mental health task force, and there's a lot of work to be done. So I was just wondering if you, having that background in your work and what you do now, have you seen any potential to reach into the area of helping parents who are threatened with child welfare involvement in their family, and to try to reduce the removals and TPRs and all those things that have pretty devastating consequences?
Oh, absolutely. Great question. I think that trap therapy, once again, is a solution to that ongoing need there. Because what we're doing in part of how we got to this place is that I quickly realized that most families weren't intentionally wanting to neglect their children. They were self-medicating. Drugs and alcohol, unfortunately, was acceptable to manage mental health symptoms oftentimes. Stressors, traumas, we drink, smoke, other substance use to medicate some of these things. So I think, again, as we talk about how do we add supports, how do we meet that need, how are we embracing those conversations around emotional wellness and really gauge a motivation to change. You don't force motivation, threaten motivation. That's an internal. We need to connect and engage and understand what's in there. What do you really want? And I think that we do that in a really unique way. And we do that in a way that's non-threatening. And we do that in a way in which people say, you know what? I'll say it as a lady described. She said, you know what? I don't really know you, but you right? And that was her way in urban vernacular saying, I don't know you from anybody else, but I trust you. You good people. I can hear in your voice that you care. And it wasn't that she heard it in my voice. She heard that I showed up again. She saw I was consistent. I did the things that I said I was going to do, right? Just like we do. We show up, we're consistent. We build engagement, trust, and rapport. But I will welcome the opportunity to join some of those conversations too. Awesome. All right, don't let me take over all your time. I mean, I like this, but there may be other people that's like, when is she gonna be quiet? All righty. Any other questions, comments, feedback? Awesome. Thank you so much.
Okay, thank you, Tarsha. Okay, we're gonna move on with the agenda. And now I'd like to introduce Mike Lappen, who hasn't been with us for a while because he's been taking care of himself. And Mike is the administrator for the Milwaukee County Behavioral Health Services. And Mike is gonna give us lots of updates and try to answer some questions. And here we go. Would you like water or something, Mike?
Thank you. So hi, everybody. It's good to be back. I did miss about 3 months there, so but I'm back. I think the last time I was here, I needed to sit down about 10 minutes into my presentation, and today I can stand the whole time. So I'm thanks. So I received some questions ahead of time. I did my best to provide some written answers. I still need to refine them a bit, but I'll go over the questions and then forward myself to questions from the group. So I believe these came from the steering committee. What is the total number of inpatient mental health hospital beds in the greater Milwaukee area, both adults and child/adolescent? So it's not totally easy to keep track of this because, well, for one, the Behavioral Health Services Division doesn't really have oversight over the hospital systems. We do try to know, but even tracking mechanisms like the Hospital Association Bed Tracker or the Center for Medicare and Medicaid Services rely on licensed beds. So for example, when BHD was in our last years of operation, we had 34 adult beds and 10 kids beds, but our licensed capacity was 144 beds. So if you look up licensed, it just doesn't, it doesn't really, it's about staffed beds. And then the other consideration is whether or not a hospital would be accepting the patient that is presenting, which is a very individual decision made by typically a physician. So, but I do have some data. I wanted to give that caveat. Our crisis services division monitors availability on a weekly basis. We have a person reaching out to all the units and asking what the beds situation is. So we get more of a real time. I have the data for March 29th for adult beds. Aurora Psych, so the old artist formerly known as Dewey, now known as Aurora Psychiatric Hospital, had 2 open beds for 60 staffed adult beds. Rogers West Dallas had 4 openings with 50 staffed adult beds. Brown Deer had 5 beds for 28 staffed beds. Granite Hills had 15 openings for 36 staffed beds. St. Francis had 5 open beds for 20 staffed. On the youth side, I don't have the open bed data. I just have the capacity. I got this data from the Milwaukee Healthcare Partnership. So as of the partnership report from February 24th, Granite Hills had 12 youth beds with a 12 to 17 target group. APH had 14, targeting 4 to 17. Rogers West Dallas had 22 beds, same as 4 to 17. Rogers had 14 beds, ages 13 to 17, so they served a slightly older population. And Brown Deer had 20 beds, 4 to 17. So those are the sort of raw numbers as they're presented. I can tell you that the kids' demand dramatically fluctuates from day to day, week to week. During the last 4 years that we were open at the Behavioral Health Division, I believe we kept it 10, and our census would be 0 to 10 in a day. So we would go from nobody on the unit to 10 beds by the next morning. It's a mysterious thing. It's hard to predict on the kids' side. There are certainly seasonal trends, but one of the challenges at Granite Hills is they had almost 0 demand for youth beds for a while, and we were pressing them to open more adult beds. So they actually pivoted from serving younger youth to serving adults because that's where the community need was. As you heard, there's lots of beds in the community for youth. I think the challenge has been serving the right youth or serving the youth that we wish they would serve. I think it's been a little more challenging. The private hospital units struggle on the Medicaid population. There's a whole complicated explanation there, but really what it comes down to is insurance and prioritizing better payers. And unfortunately, the kids that need us the most are typically Medicaid participants, as many of you know. What is the average daily cost for inpatient care at various facilities and the cost of transportation? To be clear, BHS only has a contract to pay for adult inpatient admissions for individuals held under emergency detention who are indigent. So our Granite Hills contract is about $1,000 a day. If we send someone to the state hospital at Winnebago, it's about $1,775 a day under the new rules. If you look at the most recent mental health board finance packet from last month, 2023, the budget was about 17.5 million in inpatient expenses. That data was projected in December of 23. It's probably really close. So I would say between 17.5 and 18 million is probably the number. At the time we put that data together, it wasn't finalized. I'm sure it is now, but I didn't have access to it yet. We typically don't report stuff until we report it to the mental health board first. So some of those will be in the next cost report. The way it works, just so people understand, is Granite Hills must exhaust all other payers before we will cover a stay. The other facilities admit insured individuals under memorandums of understanding that we've had for many, many years. So we have MOUs with Aurora Advocate, with Ascension, with Rogers. And so the way that works is we have an agreement that they will accept emergency detentions under a county referral, but only for insured patients. We don't pay those providers to serve individuals under emergency detention. Those MOUs were in place for at least 20 years. And historically, as an example, Aurora historically admitted just about as many patients, individual patients, as BHD did to our hospital under emergency detention. And we used to use the St. Mary's the old St. Mary's Hill facility. I don't know what the last name was before it closed, but that was probably the second highest acceptance rate for us. So when St. Mary's closed, I think that was actually a pretty substantial impact for the cases we refer to them. It's always been a much smaller number with Rogers. And mostly this is on just the acuity. So a point of advocacy, just a call to action. There's a sentence in chapter 51 that basically says that private hospitals do not have to accept people under emergency detention. It's basically says that people under emergency detention to the county department can be served by the private health system hospitals if they agree to admit that patient. So that's how it's written. But what it basically means is if you're under a commitment or you're under emergency detention, they can just say no for no reason, even if they operate a psychiatric unit within their hospital system, which frequently happens. So one of the challenges, again, in sort of expanding the numbers who are served in our general hospital beds is that as long as folks have that ability to opt out of serving the sickest folks in the most active crisis, you're going to see that those cases get aggregated elsewhere. So that's what's happened. So that's, BHD admitted patients who typically weren't admitted anywhere else. When we closed, we found it a challenge to mirror and recreate that acuity tolerance and ability to serve challenging folks in the community-based hospitals, which is a big challenge going forward, which I think will get addressed in the other questions. On the transportation side, on the rates. So again, we only pay Granite Hills and the state. All those other hospital system contracts are between them and the payers. I can't even know because that would be illegal for me to have contract knowledge of their rate setting. But they're paying whatever the insurance HMO rate negotiated rate is. Probably I would guess I would say the average day rate for a hospital is probably in the $2,000 to $3,000 range ish. Medicaid probably pays in the $1,000 range. It all depends. But again, I have no way to know that because we only fund those as a payer of last resort. The transportation piece is interesting. So we knew when we closed our hospital in PCS that for at least a certain number of folks who would have historically been admitted from PCS to the Behavioral Health Division Hospital, that we would need transportation. And people probably don't remember this, but we couldn't have an emergency room at Granite Hills because the city of West Dallas put in the development agreement for Granite Hills that they weren't allowed to operate an emergency room like PCS. So we had to pivot and come up with something new. I feel pretty good about that, but it did create a separation. So we knew this was going to happen. So what we did when we went live at the Mental Health Emergency Center, we had a group of psychiatric techs who worked at BHD, some of them PCS, some of them on the units. They were all basically slated to get let go. And so we approached the county exec's office and we internally had discussions about funding a transport team. So these are extremely experienced folks, many of them who knew some of the people we served, who were excited about providing the service. So we created from scratch a crisis our transport team. The hope was to eventually align it with our crisis services. Not every part of transport can be attributed to crisis, but if you're taking someone from the Mental Health Emergency Center to an appointment at a federally qualified health center and you have a crisis plan, that would be a reimbursable service. So the idea was to try to offset the revenue. That wasn't our first goal, though. Our first goal was to make sure there was safe and appropriate transportation for the people we serve. So that's what we did. Under Chapter 51, the county has a responsibility for a small population of folks under the supervision of the county department. We serve many, many more than that because, again, we wanted to do the right thing. Historically, transport has been handled by private transport companies, taxis, in some cases, law enforcement. And so today, the data I have in 2023, it was $382,000 went to the transport team. We're projecting $582,000 in 2024. Really, the difference is really the utilization of that service wasn't as high at first, and it really ramped up, and that we had a lot of open positions by the end of 23. So there's some 582 is probably, it's probably between $500,000 and $600,000. When there's a doctor's order, basically when a physician who's assessing our patient identifies that an individual cannot be transported by that team. And that decision gets made because our transport team can't go hands-on. So they're not gonna, if someone tries to elope, we're not gonna tackle people, we're not gonna chase people. We just can't, we don't have the ability to put, that's a law enforcement kind of function or a specialized function. My team is great and they've transported a bunch of folks that are, not doing real well, but their de-escalation and really, it's not even de-escalation as they approach the situation with so much dignity and respect for the customer that they don't have challenges because people trust them. But when, 1%-ish of the time, we need to use specialized transport, we have two options. We often use ready transport because they'll respond immediately. Those are typically transports to the state hospital. And then sometimes we have to rely on law enforcement with a sheriff's order. That is our absolute last resort. I don't really want people transported by law enforcement, just in general. The challenge there, though, is they have a responsibility to serve us. And if we can't muster another opportunity, we need secure transport. It really comes down to just have to utilize law enforcement here and there. You're talking maybe a dozen rides a year out of 8,000 visits at the mental health emergency center. So it's a really small number. So that's that. Please describe the linkages and partnership between inpatient providers, access clinics, CART, and mobile teams. So, and maybe we can flesh this out. Maybe you can give me more to work with here, but CART would have a really limited role. I don't really see how CART would fit in that math around inpatient providers. Although there's a world where, well, it's not a really direct relationship. Crisis Mobile does provide follow-up services. The service that started out as Team Connect, which was our branded service, really has just been rolled up under the mobile team. We've talked about this before at a previous presentation, but we had a specialty team for youth, we had a specialty team for adults, we had a specialty team for individuals with developmental disabilities. And what was happening is the community was getting kind of confused about who to call when. And so we just consolidated everything to Milwaukee Mobile Crisis. The idea is that our clinicians would just figure out what the best response was. And frankly, if we couldn't send the best response, we would send the next best response or whatever response we could muster in the moment. The goal is to expect that everyone has the skills to serve any target population in our community, which our teams do, right? And there's a benefit to specialty, but then you also, when you're responding to a youth, but the whole family is there, then are you providing a youth service or are you providing a family service? You can see where I'm going here. So, yes, we're involved in follow-ups. I have some numbers I can share about follow-ups and referrals to our organization's different programs. But again, it's a person-centered response. There's no generic, like everybody doesn't get a follow-up because half the people we serve through the mental health emergency center and through Granite Hills are enrolled in a program. And so sometimes it's better to have that follow-up be directly to that provider. So the person might be in a community support program, or they might be a CCS participant, or they may identify a person that works with them that helps them. We really make those decisions based on the individual, not on any sort of protocol. It would be a tremendous waste of resources just to have a standard response. Team Connect was a very successful service, but the contact rate dropped very substantially after the first couple of months. We just weren't getting a hold of people. And so we believe this is a little more effective because we're targeting those folks that ask us for a follow-up or, it's part of their plan. We see a lot more when people make choices, obviously, when we honor their choices, they're more likely to follow up with those services. So we've kind of gotten away from this sort of rote, everybody gets the same response. The teams do regularly meet, by the way, so Access Clinic folks, our Crisis Mobile team joins the Mental Health Emergency Center staff meeting every Monday. We're really in constant conversation with how we might better partner, problem solve a referral that didn't go well. Problems happen. Things don't always work out as we plan. So those get addressed on a weekly basis, and really every day there are conversations around this sort of thing. Is there a formal discharge planning process between BHS cars and the Mental Health Emergency Center in Granite Hills? Are there any face-to-face warm handoffs? So same idea. I mean, discharge planning is a person-centered endeavor. Each facility has its own discharge planning responsibilities. One of the things about sort of the Granite Hills contract and really our relationships with all the hospitals are, we've always felt that hospitals are, you know, among the most regulated operations in the country, right? So it's not our job to tell hospitals how to, you know, follow the Joint Commission requirements, follow the CMS rules. They have to deliver a quality discharge planning product. What we hope is that we're involved, and when we have a community-based service that should be coordinating care, we want the hospital to reach out to that provider, and we want that provider to be in contact with the hospital. I think early on with Granite Hills, they struggled a bit there. I know WCS is here. I know we problem solved a couple cases with your CSP. They're getting much more knowledgeable and have made some substantial improvements. It wasn't just Granite Hills, though. I think, you know, with all the staffing challenges, with all the changes in the community, with all the stories that get told in the community about how things really are, versus what the real service are. So, you know, people believe there aren't services when there are robust services. You may just not know about them. And so we've made some improvements in awareness. And I think now there's an assumption that when county county department folks are referred to the facilities, there's an assumption that yes, there must be some other service in place. And there's more of a proactive approach to connecting with those services. So we did in 2023, we had 4,515 referrals from all of the different access points for cars. This is adult data. 23% of those referrals came from hospital providers. So 1,038 referrals came from community hospital providers. So to dig into that data a little bit, that's 1,038 folks who weren't already engaged in some sort of community-based service for adults. And we have about 1,257 referrals to date through Q1 in 2024. So there's some evidence that those referrals are happening. On the youth side, for wraparound reach, CCS and FIS, we had 987 total referrals in 23. 110 of them were initiated by the Mental Health Emergency Center. There's 11% of those referrals came from the hospitals in general. There's a code, and you guys probably know this better than me. There's a hospital checkbox that gets checked in a referral to a WRAP program. So that's how we tracked that. 2024, we're at about 256 referrals for the first quarter, so pretty much on track. 18 of those referrals came from MHEC, and it looks like about 7% of referrals came from just hospitals outside of there. So gives you a kind of an idea. We do have a psychologist. Some of you might remember Dr. Macri, who worked at BHD on our acute unit. He was on the list of folks to be laid off when we closed the facility, and recognizing that we had a brand new inpatient provider serving the folks that we served for, 142 years. We decided to embed Dr. Macri at Granite Hills to help manage those individuals who are under some sort of county department order, so some sort of emergency detention or essentially an involuntary hold. He provides consultation on all of the treatment plans, gives some guidance around things like settlement agreements and really sort of general care, and then acts as a liaison between the Mental Health Emergency Center and the hospitals that receive patients from the Mental Health Emergency Center. Initially, it was like just to make sure the paperwork was right. And then at this point now, it's more of a quality and consultative relationship where he's providing 25 years of experience serving this target group to providers who don't have that experience. So we knew this was going to be a challenge, and that was one of the investments we made, and we're committed to maintaining that long term. He has great specific skills, but the concept have proven to work well, and I think people are better informed about how the legal system works. There's a lot of questions about the legal stuff, as you all know. That's a common challenge. Number 5, how many are eventually admitted to reentry programs? It's a term typically applied to like coming out of prison or jail. I don't know that it applies here. So maybe you guys can help me with that, where that question came from. The 6th question is, what is the recidivism rate of Granite Hills and MHEC? We've heard they're in, out, and back in again. So I don't know that I would use the term recidivism here. And in fact, I think it's actually kind of stigmatizing, sort of out of character for the task force. So not to be that guy, that's not the term I would use. If I was very sick So my third time I went to emergency for my spine because I couldn't walk, no one was like, oh, the recidivist is here again, right? No, I got mental health is a medical condition. These are, this isn't jail. This isn't, people should not be looked at as recidivating when they seek help. So just for what it's worth. It's not linear in recovery. Going to the mental health emergency center 10 times doesn't mean that all 10 presentations weren't appropriate. Remember, we put in people's treatment plans, things like, if I'm feeling unsafe, I should go to the mental health emergency center, right? So just for the record here, we had 7,163 visits from September of 22 to September of 23, 4,166 individuals. So that was the first year data. We're on pace for about 8,500 cases a year at the mental health emergency center. The first year's data is a little skewed because it took a little while for it to ramp up, but we're right at about 22 to 25 cases a day, about 8,500 a year. I would bet that encounter data is very consistent to that at PCS. There's some folks that have lots of visits for lots of person-centered reasons. And, my philosophy on that is, we treat people with dignity and respect. Maybe they don't want what we have to offer that day, but they come back. That's a good thing. That means we're doing the right thing. Likewise, we have a lot of presentations at MHEC and we had a PCS where I'll use the term voluntold. So someone says, come with us to the mental health emergency center or whatever. And so the person presents there. We go through the assessment. The person isn't an involuntary customer, they're a voluntary customer. We offer something, they say they don't want it, they ask if they can leave. We can't hold them. We have to let them go. And so some of these cases reflect this. People are brought there with an expectation. That expectation is actually different than the customer's expectation. It's a family member, it's a police officer. Law enforcement in Milwaukee, I will say, is amazing in that they will take anybody at any time voluntarily for mental health services. It's part of their protocol. But it means that some folks arrive with law enforcement as voluntary customers. And as soon as law enforcement leaves, people are like, I can leave, right? And at MPAC, we have to let you go. It's right in the statute. So if we can't find probable cause, we can't document that you're a candidate for emergency detention. We can only offer voluntary care. If you ask to leave, the law says very specifically, you shall immediately be discharged. So that's what happens. So, there was a question, how many referrals are made to community-based services? I kind of covered that in item 4. So now you get the live version. So if the folks have live questions or things in the moment, I'm happy to answer them.
Hold on this time. Okay, I'm gonna run the microphone to people.
I'd like to thank you for sharing. Good to see your help. One of my questions, well, it's 2 questions really. One, and I'm dealing with real events with myself. One is the criteria for chapter 51. Back down. The criteria is so high. The criteria is critical. My son had 6 events. 3 of them were altercations that were physical, but because I wouldn't charge. Police would not take it. Oh, and they couldn't charge on it. But the criteria in Milwaukee is essentially they have to be committing a crime. And they don't word it that way. But when they're there at your door, they make you understand if we're not watching him hurt someone, or he's not hurting himself. And he doesn't want to go with us, even though he may be like my son, who stood in front of police officers asking them to shoot him. Which evidently that is sane because the officer said, well, he's in his house. I mean, he wasn't armed. I am getting tapes, and I really would like to have people like you sit down and see these things in real life events that are happening. Because what's happening is lives are going, there's going to be people dying. When my son was at his worst, every time he walked out the door, I didn't know if maybe he was gonna be dad or someone else. When his employer calls me and tells me, you know, Pete, I can't let your son do so anymore. And you know, he's gonna get killed. They're gonna kill him on the street. That's the call that I get, and yet the police, our hands are tied. We can't do this. We've got police that have been admitted to us. There's nowhere to take them. And that they're out within, even if we do a 51, they're out within hours or the next day. So something's gotta change. And I understand, and we're at admire here and hoping others can come together with us to try and change legislation, because this has gotta change. It's wrong, absolutely wrong. It's inhumane, because the thing you're doing is you're violating their rights. They're gonna hurt somebody, if not themselves. My tooth is missing. I've got a scar over my face, but I'm not gonna send my son to jail. He's sick, just like you said. But you know what? If it's chapter 51, they won't do it. Mike, they don't do it. And I'm not saying you're the answer. But I know you know people that can start putting pressure on why this isn't happening in the city. And when it comes to beds, Sampson's actually supposed to have 50 beds for 100,000 people site beds. That means there should be 500 site beds in Milwaukee. That comes from Sampson. I'm not making, you know, you can look this stuff up. Somewhere we're missing the boat. What happened? When the county closed, I mean, there's nowhere. My son who can get violent, there's nowhere to take him because there's no security anywhere. Randy Hills isn't going to take him. He's going to be a threat to their staff, and I don't blame him. So, what happened?
So the criteria for chapter 51, which I think we have some very capable lawyers in the room who could help me on this one, but in Wisconsin, it's imminent dangerousness to self or others. You know, there's something like 22 different court decisions that have sort of led to where that is today. The criteria is that a person has a mental illness, that they respond for treatment, and that they're imminently dangerous or to self or others. I really can't comment, and I don't know what happened with the law enforcement. And we talked, you've sent me some information, we chatted a little bit. We're also one of 2 states where law enforcement essentially is the only agent that can initiate an emergency detention, us in Kansas. But the truth is, we have had beds, aside from Thanksgiving Day, 2023, that's the only day that I am aware of that we haven't had a bed to receive a person under chapter 51 under the county department. Now, you're correct that some facilities don't accept because of acuity, particularly when individuals are projecting violence onto staff. Granite Hills started out, they really struggled to admit folks. They've come along, they've taken a larger percentage of higher acuity cases, as has Aurora Advocate. So they've taken on a higher acuity. They admitted about twice as many folks last year at Aurora that they served the years before under the previous arrangement. So everybody has stepped up. I attribute that to the fact that the Aurora staff work for Aurora and also the Mental Health Emergency Center. So there's some doc to doc transfer. There's some helping out their sort of system. When people exceed that level of acuity, we send them to the state hospital. It's the last resort. The state hospital is the only facility in Wisconsin that must accept. So we utilize Winnebago State Hospital. But the criteria piece, I'm not in a position to change it, nor are any of us. I mean, these are Supreme Court decisions. Locally, there's been a really strong focus on that rule, and it has gotten more challenging over time to commit folks. It just has. I mean, the cases get thrown out on what seems like kind of technicalities, but that's the way the world works. And I believe law enforcement sometimes misunderstands the system in that they take a person to, I'll use PCS, which is closed. Take someone to PCS. They have no idea what happened to that person at PCS. They see the person on the street the next day and they assume that that person was just discharged and nobody cares, this whole story. So the next time they're like, I'm not even gonna bother. But I've had crisis staff and I've had community clinicians in the community and people who work for the housing division say, this person is clearly a candidate for emergency detention, and a law enforcement officer has said to them, nope, we're not gonna bother. And so I do think there's some sort of, they're making a decision based on their experience. And maybe in your case, there's some history there that I'm not aware of, but they're assuming that they know what's gonna happen. The truth is, we would rather have them come and be assessed by a physician who would actually make that. And that's the one thing that chapter 51 is very specific in Milwaukee is everyone who is brought in under emergency detention sees a physician within 24 hours. And that happens at the mental health emergency center. So we do have something in place for when they hit the door, they get assessed. Whether or not they meet criteria in the moment is another question. And again, the threshold for dangerousness is pretty severe. This isn't, it gets down to, I mean, we've had cases challenged over, we make a case that someone's not dressed appropriately for the weather, and the temperature outside and the wind chill factor gets brought up in the hearing about what's the threshold for dangerous? Is it 0? Is it 10 below? Is it 35? I mean, it gets that specific. And the lawyers assigned to those cases, their job is to represent their customer. If their customer doesn't want to be committed, they're going to do everything they can to have that case thrown out. So again, it's the totality of sort of all those court decisions have really led to where we are today. And do I think it should be easier? I don't know. I really don't know. My experience is the best way to partner with or to get people along the path to recovery is to find a way to it for them. And I see a lot of families who, since the kid was 10, they are really harping on them for meds. Take your meds, take your meds, take your meds. And now they're 40 and all they hear when you talk about mental health treatment is meds, meds, meds. And people just, they don't want to hear it. And it immediately alienates them from that conversation, because to them, meds is, it's compliance, it's meds. It's not about what's in it for me. And so I've had better success being like, okay, what would be a great outcome for you, and kind of focusing on that. And then, use the motivational interviewing angle of when their life is better on meds, have the conversation. So what's different about your life today? You know what I mean? And again, I'm drastically oversimplifying this, but that is those lead to better results long-term. The commitments essentially create this, you're a subject of commitment. That's the term. So you're a subject of commitment. Like, it's not like I'm getting help. I am, just like I'm on probation, just like I'm being arrested. To the customer, it feels like an arrest. And the whole system seems like a punishment. And that dynamic really alienates a particular group of folks. And many of them, and we've heard the term, Meyer has put it out in a lot of your work, anosia. It's essentially the syndrome that says you don't have any idea that you're sick. Some of the folks we're talking about are in that position. So it's not ideal, but I also believe there's some misunderstandings about what the law is, and the decisions that are being made by the mental health emergency center physicians are very sound. I have not been privy to a decision that I question based on the documentation or the profile. Like, they're making good decisions within the law, and people aren't always happy with them, but and it's an entirely different team. There was almost zero overlap the first year. Now we're seeing some former PCS docs coming on board, and Dr. Owen, who was just announced as the leader there formally. She did work at PCS at one time, but we meet with them. I meet with her personally every week. We talk about cases. She has sought tons of guidance, and we do a lot of education on those physicians. And the data is really strong that they're making good decisions within the law. If the law were to change, we would make good decisions within the new law. But that, the notion that people don't get committed. I mean, we did like 3,700 last year, something along those lines. I don't even know off the top of my head, but it's literally thousands of folks did get brought in, under emergency detention. The other pathway is the 3-party petition, which we talked about. 3-party petition is different than an emergency detention in that you can provide testimony about 60 days worth of dangerous behavior. So for families, it's helpful because you can say, well, on this day, I felt threatened because of this, and there's not that imminency. It also skips the part about the treatment director's supplement that has to be done at the mental health emergency center, because when a 3-party petition is approved by the court commissioner, it's basically an order to admit and assess, so that there is no sort of treatment director's decision at MHEC. That person essentially proceeds to a probable cause hearing from there. So it's a little different of a system, and it's getting really wonky, but there's some power to the 3-party because you can really create a history of dangerousness and concern, you can also have the time to really compose your thoughts. I will tell you that I've seen law enforcement emergency detentions that say things like, "Mom told me to bring them to PCS, period." The only thing admittable in a probable cause hearing for an emergency detention is what's written on the blue form by law enforcement. So that one got thrown out the door. You know, and that's, I'm not even joking, like it literally said that. So that's the quality of the documentation is an issue, and that's where training is a big deal. All right, am I done?
Yes, first of all, sorry about that word recidivism. That's, I think, in my language, and we barely use it, but, thank you. We really missed you, and I think I can tell you missed us too.
I did. It's great to be back.
Yeah, thank you so much, and, oh, the one more comment before, can you, when he's done, can you introduce, Dr. Cole?
Oh, of course.
Okay.
I know that at the state level, there was just legislation that was passed that says that law enforcement will have the ability to use tablets, and they'll be able to do like telehealth and things like that. I'm wondering if there is a way for the county to partner with the state to possibly put in some type of PDF or like basically standards, so that a situation like you just mentioned, mom said, bring them to PCS, right? But maybe there's like multiple choice or 0 to 10, because if they're going to get those tablets and they'll be able to actually use that technology, maybe we can empower them. Like you mentioned the blue form, and I just want to know, what were your thoughts on that? And then how can the task force support you, especially when we talk about legislation, lobbying, change? And the last part is just what's ideal? Like if you could have the perfect scenario, like, hey, this is what we have, but if we were able to do this, this, and this, we could have folks that come together in spaces like this advocate for it.
I think there's nobody from the hospital association here. I would say the number one lobbying thing is to take that sentence out of chapter 51, because it really creates the us versus them. It's the county patient versus everybody else. So I think we've resolved that here a little bit. It's changed in Milwaukee because of our partnership with the health system. So they also fund the mental health emergency center. We sort of all agreed we were all in it together. But in the balance of state, that sentence in chapter 51 means something like 90% of emergency detentions go straight to the state hospital, which is not cool. And most of those get thrown out at probable cause because they weren't appropriate. So you disrupted someone's lives for 5 days for no reason. On the tablet thing, I think that the nuance though to that legislation is that there's a particular vendor that's been identified to provide that tablet service, as opposed to the idea that you could do some sort of telehealth. We regularly have Tony Thrasher, Dr. Thrasher available to do consultation with mobile, with CART, and with law enforcement. We have a system like that. We would completely embrace an ability to do that mobile. At this point, though, it's more efficient just to use the phone. The place that I've seen tablets work really well is in communities where they don't have doctors. They'll literally do like an on-the-spot psychiatry appointment on a tablet. They did that in Houston. And it was really great. The people in Houston basically told me like we could never get there in time. So the tablet really helped. So that whoever is the first responder could connect the person to a mental health professional. You know, here, I think we would prefer face-to-face, and we have the resources to do it. So I think there's something there. I think though the state initiative is targeting something different. And it's really being promoted by the provider who's going to do it. So. Yeah.
You need a microphone?
Yes.
Oh, I don't need that.
People are online.
Mike, you gave us a lot of information. I wrote fast. Is there any way we can get that, the task force can get the written information?
Yes, I will submit what I wrote. I do want to edit it and clean it up a little bit. The request came in, I believe, late Friday, so I didn't have a whole lot of time to refine my numbers here. We will. Is Dr. Cole online? Wonder if we got our communication set about today, because he's on your agenda, right?
Next.
Okay.
Oh,
I can stand in for him.
yeah, you can keep.
Okay.
I have a question,
It's not
Mike.
gonna be as good as if Dr. Cole did it, but I'm happy to talk about the access clinics.
Question for you. This is,
I'm good. I need to stand. My physical therapist is always gonna he wants me standing, so.
Quick question. So, first of all, thank you for the presentation, very helpful. And you're doing better, always happy to see that. So you mentioned that I think MHEC is projected to have about 8,500 admissions in 2024, is that correct?
Mhm.
So is that something that you anticipated 3-4 years ago? I mean, if you can think back to what you saw in terms of the numbers MHEC would be serving, would it have been that number?
Yeah, so the 2019 PCS number was 7,456.
Yes.
So when we worked with Rob Henkin and the Policy Forum in 2018, the projection was that the new center, which was this idea at that point, should be designed to serve between 6,000 and 8,000 individuals. That was the feedback, that was the direction. Couple of caveats, that was pre-COVID, so the world did change a bit. But the intent was that we would minimize the number of people seeking emergency room services because we would expand crisis mobile cart, all those other things. And so I think the reason we only see 8,000 or so visits, even with COVID, is that people are utilizing those other levels of care. I just was working with Director LeGrant McLean on the annual report, and we had 32,000 crisis calls last year, which is like 10,000 more than we had in 2018. So the community-based response is probably better. We've struggled through staffing, but we're finally getting to the place where we have enough staff. Likewise, all the agencies we work with are struggling, as you know. But the number is probably right. I mean, the capacity between 6,000 and 8,000 makes sense. I think we need to work with folks to, when there is when someone comes up on our radar, when someone has a visit, to make sure we do a better job of making sure that visit's the only one they need, because after that they know who to call. We do still do some visits that are probably unnecessary, although we still welcome people. But an individual who may have just gone to the access clinic for outpatient services, or if they had known, you know what I mean? So my sense is with a robust community awareness campaign and more knowledge, the capacity is there. It's a really specialized thing. So, and the idea is really not to treat people there. Well, it is, but it's to get them to the thing they really need as quickly as possible. So whether it's inpatient or community-based services, the average duration of an emergency room stay at MHEC is about 12.5 hours. And there's about a 20% admission rate, which is consistent with PCS. It's also consistent with any emergency room for medical issues. But 20% of the time people show up in the ER and they end up admitted.
You have the staff there now to handle that level of capacity, you think?
Yeah, they've done a great job. They've had very limited turnover. Granite Hills had a lot of turnover, but MHEC's been really solid. The 11 people that used to work for me that work there, I think 10 of them are still there. So that's cool. Like really experienced folks. So I'm happy to see that. So it sounds like we may have had our wires crossed with Dr. Cole. I know he did a presentation about what you wanted about Access Clinic, but maybe I can just talk a little bit about Access, and if people have specific
Can
questions.
you give us PowerPoint?
It just very well could be my fault. I guess I thought you guys talked to him directly. Maybe I was supposed to arrange this. So we've relatively recently opened within the last year. So in 2023, Access Clinic North, which is at the Isaac Cox Heritage Clinic on 82nd and Silver Spring. So this really completed a long-standing plan, which took us like 6 years to achieve, where we went from an access clinic at the Behavioral Health Division Hospital that had been operated for many years to clinics embedded within federally qualified health centers in Milwaukee. So we have a facility, we have staff at 16th Street Community Health Center on 16th and National. We have staff at Outreach Community Health Center on 2nd and Capitol. And now we have a team at what we call Access North at the Cogs Clinic, working with Dr. Izzard and his team. The concept here was that each of the FQHCs, the federally qualified health centers, I believe they prefer to be called community health centers, right? That's their preferred term. So the community health centers have these great programs. They do behavioral health care, outpatient care. Where they really struggled was when people came in crisis, and a really acute crisis, particularly people who might be more disruptive than the average person walking into their clinics. And so we felt like that was our strength. And so what we did is we co-located a team licensed under the DHS 34 crisis benefit. Our original plan was to have our own outpatient clinic. The state told us that you can't have two DHS 35 outpatient clinic license is at the same address. And so that's why we really sort of narrowed our focus to those crisis services. So you can walk into an access clinic now and you will always be seen by a licensed mental health professional who's part of our crisis service, who has access to all of the VHS delivered assets in the community. They also are on our electronic health records, so they'll know if you have a connection or whatever. But we have physicians, we have nurse prescribers, we have certified peer specialists, and we have licensed professional mental health professionals available at all those locations to provide that immediate, right in the moment crisis response, really whatever that means. Many times it's a mobilization of all kinds of services for an individual, connecting them to different services, making a CARS referral. The most common thing people need are a medication management appointments. We also have pharmacy contracts. We have a contract through outreach. So if folks are indigent and they can't afford their meds, we will provide them at no cost to them. These services are free. We bill Medicaid when we can, but that is not a deal breaker. We serve people all the time without really getting to the insurance part of the conversation. That's not what we're after. What we're after there is to maintain that community connection, provide people immediate access to those services. 16th Street is the most mature of the programs. It was the first one that opened. They also have a substantial amount of co-located services. Their CCS programs are there. And so the volumes at 16th Street have been higher than the other clinics. But that doesn't mean the other clinics aren't very important and in key locations. All the clinic locations are based on sort of trying to have complete community coverage for that service. We'd love to see more utilization, and we're in the process of working with the health systems so that when someone presents to a community mental health or emergency room with a mental health issue, and they don't have the ability to access an outpatient appointment, they can get connected to the access clinics directly. And they make those referrals today. We're trying to get on their platform. I can't remember the name of the platform. It was called like Community Connect at one point. There's now a new version of that where a referral can go right from that emergency room to a provider. And so we've been working really closely with them. And I just was speaking with Dr. Cole about this yesterday. There is a path where they can just make a really easy referral. It's like a one-click referral, and then have that person follow up with their access clinics. So that's the program. That's the basics of the program. We also have a clinic that is initially focused on youth on 19th and North. This is what we call the Milwaukee County Mental Health Clinic. Pretty boring name, I know, but we specifically did not call it our youth clinic because the idea is eventually we might serve adults there. But that clinic basically took the access clinic for youth that was called the Wraparound Wellness Clinic out at BHD and served a very tiny population. And it moved it into a community location on the north side where lots of the folks we serve live and their families. And we basically, instead of laying off all the child psychiatrists in the child and adolescent inpatient service at BHD, we convinced them to stay on and work as outpatient prescribers at our clinic. Today, that clinic serves people enrolled in RAP, people enrolled with the CCS program for youth. We're working really hard to expand referrals and take more cases. We've really struggled in managing a large population. There's a whole change at Wraparound that I probably will get asked about now that I brought it up. But
Yes.
there are some folks, we want to make sure that nobody gets left behind. At a local major health system, if you are asking to see a child psychiatrist, you're waiting 18 months for your first appointment. That is just not cool. We can't let our kids who are vulnerable and need immediate attention wait 18 months. So we just have to find a way to make sure that our capacity is best targeting the people who need us most. We've got some amazing providers there with lots of experience. So Dr. Moisio, Shane Moisio was the medical director for our inpatient service at BHS. Dr. McClymans has worked with youth and adolescents for many, many years. Dr. Stevens was formerly a mental health board member, and he was a children's hospital employee. He actually resigned from the mental health board because he really wanted to work at this clinic. So we have really mission-aligned folks there. Very recently, we've added 2 postdoctoral fellows there as a training opportunity and a licensed therapist. We also brought in a clinic manager who's a person seeking their licensure as an outpatient therapist. And that is just the basic bones of what the clinic will be. Typically, outpatient clinics are really heavy on therapists and really light on psychiatry. Because we were blessed with psychiatry, we're extremely heavily on psychiatry, and we have to develop the therapy piece. So in the coming weeks and months, you will see us look to expand It'd be great if we could do some trap therapy out of the clinic. So I'll make that connection, Tarsha. But that is sort of the last really missing piece in our system, and that it's really hard to get kids seen. And if especially see a psychiatrist, especially a psychiatrist who understands the complexities of the folks we serve. We currently have a program called CORE, which is a CCS program, but it's a program intended to serve youth who are experiencing their first episode of psychosis. So there's a whole model of this care. The idea is that when kids get help immediately after demonstrating some significant symptoms, their entire life course changes for the better. So that the more adequately you serve those individuals when they're having that first episode. And not everybody goes on to develop schizophrenia or have a challenge of that nature, but for the ones that do, that initial service, that adequate medication management, really getting that connection to care in the right way, just dramatically impacts their education outcomes, employment outcomes. I mean, the data is amazing. And so we have a number of teams delivering CORE. I think we're actually about to expand. There's a fancy name at the state for it. It's coordinated specialty care, I believe. So we receive substantial grant funds to support that CORE program. In Wisconsin, there's now a 10% holdback of the federal block grant dollars that come to the state to provide first episode services. We're one of 2 programs in the state today. There's one program up north that has like 9 counties and 50 participants. We have something like 700 kids in the program. So the cool thing is there's pretty much unlimited funding to make this work. And so we continue to expand that program and that service. A key piece of that puzzle, though, is to having psychiatry available. And so always a big part of the clinic's portfolio are going to be people enrolled in CORE and in CCS and in the RAP programs. But we want to get to a place where anybody could walk in on the street and get a really helpful time with us. So that's our next prize. So, yes.
Could you talk a little bit more about how you work with like wraparound in CCS? Because I want to say that I was actually a CCS youth for 8 years. I started off in CORE and then transitioned to a couple other programs before transitioning and kind of graduating out of CCS. But I will say that before I started with CCS and CORE specifically, I had been inpatient 8 times for an average of 11 days. And after being enrolled, I was only inpatient once for 3 days. So it definitely makes a huge difference. And I was wondering if there's any sort of initiative, especially since you mentioned a lot of people that come in for the first time into different beds are have not had any sort of services before. Is there any help or any sort of connectivity to help people get connected to wraparound CCS, all these different programs?
So thanks for sharing your story, because I think it's really powerful to hear actual accounts. So thank you. We do work very hard to educate folks about those services, and maybe we didn't do that very well 8 years ago, but in today's world we do. One of the initiatives led by Director LeGrand McLean was to combine the long-term support waiver assessments with the assessments for CCS and all those programs. Again, I hate talking too wonky, but there's a required functional assessment required by the state that used to be done in 3 separate spots. Now we have a single person does that assessment and then provides education to families about all their options, and we let the customers choose what their options are. We used to never have people dually enrolled in CLTS programs, CCS programs, and now we have literally hundreds. And that was achieved only in the last year or 2. And so we see our services provide to youth and adults as really a continuum of care, really a greater continuum of care. And I would just say we have, Crisis Mobile has a role, access clinics have a role, the youth clinic has a role, the youth services provided through wraparound CCS CORE have a role, the adult programs through CARS have a role, crisis resource centers, crisis stabilization houses, on and on and on. All of these things really are part of a enormous continuum of care. The idea was to keep people from unnecessarily being hospitalized and to really keep things as voluntary and client choice driven and recovery driven as possible. So it worked out in your case, and I'm glad to hear that. That's awesome. And there are a lot of stories. Sadly, people don't share the positive stories. I think we really focus a lot on those negative stories, or when people their expectations weren't met. So I think a big challenge for us is getting the word out. And I might try to tap you for a testimonial someday. The better we can sell these programs as having positive outcomes, I think we'll see more utilization. And for CCS specifically and for core, I mean, the capacity is only limited by our ability to hire people to do the work. There is no financial challenge for us. CCS is fully reimbursed. So there's no county tax levy really into that program, any additional tax levy to grow it. And our providers are pretty well paid. I'm sure they'd love to be paid more, but the way the program is structured actually works for those providers. Likewise, our crisis service is funded in a way that really doesn't cost us any money to expand. The biggest challenge has been, you know, we had 38 openings or something when I went on medical leave. We're down to like 12, so that's cool. But it really comes down to just having enough people to deliver the services and really the right people. I mean, we only want awesome therapists at our clinic. We only want really effective folks. And so it's been a challenge. It's a demanding job and it burns people out quick. And for those of us who've been a CSP case manager, you know, like you're all things and everything to people 24/7, 365, no matter what. And that wears on folks. And especially today, it's been really hard to cover like second shift, third shift, weekends, holidays, and that sort of thing. But that's really our only limitation. The sky's the limit from a wanting and from a, you know, we have the program, we have great providers. It's really been staff, and that's at all levels of care. Dr. Apple?
Yeah, I just want to say something good about the core program. I have referred people there, and if it's not clear to everybody, I've referred people up to the age of, I think, 24. So it's really, we mentioned kids, I think it's 24.
23.
23, but yeah, so in whatever system you work in, it's kids and young adults. And it's a wonderful program.
And it might be time for us, I know we typically presented here, Maria Castillo, who works for Wraparound, does amazing presentations about those resources. We do them all the time, but I think we could do them every month. You know, I think it's hard. There's always turnover, new people, new voices, so.
This is actually a question, as far as, you know, you're talking about the access clinics and meeting therapists and, you know, programs like that. Do you offer any type of internship, like to, you know, an individual like this? Because I know from my own mental health issues and recovery and substance disorders, the people I get the best help from are those that have suffered similar to myself. And I've had therapists who basically said, you know, just keep going to your meetings and stop paying me because you're getting more out of what you're getting there to where I had grown to. You know, I mean, it's not like they want to go get out of here. We don't want to talk to you. It's like, you know, you'll get more from those people than I can give you anymore. You know, you've gotten as much as I can give you.
Well, hallelujah, they're going to accuse me of planting you here, but you know, that is the idea. And you know, on the peer side, you know, that's why we've launched the Peer Specialist Academy. We're going to have, I want to say it's 88 opportunities for people to become certified peer specialists. On the internship side, I'm super proud of what we've done. So in 3 years, we went from like 2 internships to 22, including, I want to say we're up to 6 paid internships curated through the Behavioral Health Division. 2 paid internships came through the MacArthur Safety and Justice Challenge, which we just continued to fund. And then we have therapy interns, we have crisis mobile interns, we have multiple postdoctoral fellows. Those are paid, the fellowships are paid as well. So we believe very strongly, and really it was an offshoot of a lot of work of the MC3 collective around creating opportunities for folks to learn about the services and learn what's being provided and then help them get to be licensed folks, because to be a licensed therapist in Wisconsin takes about 7 years minimum, right? So 4 years of college, 2 years of grad school, probably 8 years actually, because by the time you get your hours, you need 3,000 hours to become an LCSW or an LPC. So it's a really tough path. When I did it, I had to do it for free. So I got my hours as a volunteer essentially. It's impossible in 2024 to ask people to like work for free for 2 years. So we have to find ways to provide those internships experiences. We are rich in experience and supervision capabilities. So that's our in-kind donation here. We have the folks to help provide the clinical supervision. What we need is places for folks to work. And so we're really open to the concept. Some of providers have more internships than others. You WCS, I keep picking on you because I used to work there. In the nineties, I want to say we had 8 interns just in the CSP program at WCS. Many of them are still in the system right now. That's where I met my wife. So that's why I was
Yes.
So my wife was an intern in CSP at the time.
All things to all people.
Right, there's a whole bunch of folks currently in pretty significant levels in my organization and others that came out of that program. They did their internship. My wife's out of town, so I'll mention her again. She was wanting to work with kids, got assigned to the adult CSP and forever after worked with adults with serious mental illness. I mean, it was like that door opened for many of us. That was our first experience working with that population, working in the community. So internships are key. My sense is there's a lot of folks in the world right now who have no idea how many opportunities they have in our system. It's really daunting though, to get your master's degree and your license for anybody. It takes forever. The certified peer specialist route, I think, is a little more accessible, but it's a thing. These are professionals who have and so we've tried to create a culture where people can become peer specialists that can do some work working towards their licensure. We've lowered the requirements for the mobile team. So we have folks with bachelor's degrees working on the mobile team. So when we send out a team, one of the people is always licensed. But it used to be we only hired people with LCSWs. We had to evolve because we were turning away people that really were valuable resources to our community. The hope though is that sort of will ease them along their road to licensure, because nowadays you can go to school in a night class, your work counts towards your license. We have great clinical supervision. The idea is to continue to grow a workforce that actually reflects our community. So we're all over this, and any partnerships anyone wants to talk about, I'm all ears, because we have a workforce development for diversity and inclusion program. It has turned into like 8 staff with really broad scope. Additionally, in that same vein, we're trying to get to a place where we can provide trainings around quality, things like person-centered planning, things like trauma-informed care, where we can provide that training for free to our provider networks. Because we know that our provider networks don't have a lot of extra money laying around, and our rates aren't great. So our hope is that's where we can use our county infrastructure to provide those trainings. And I've done this for years. I mean, people like Dr. Tony Thrasher have done, 1 million CIT trainings to the MPD over the years. But we have lots of great assets to share. We also have really important community partnerships. And not to pick on Christine, but she did a great presentation for Senator Baldwin about your family-centered recovery program. Like, I am positive she never heard about that before, right? Like, people don't understand what we have here. And the first thing people need to know is like what we all have going for us, and they might get excited about being part of the team. And we don't do a great job about bragging out here, and it kills me. There's a lot of really important work being done in Milwaukee. We get more credit nationally than we do locally. I mean, ever since we had the Bloomberg folks here for the Opioid Solutions Network, I mean, I get calls from all over the country about what we're doing here around recovery, prevention, awareness, and whatnot. So I think we need to lean into the fact that we're actually doing some things right here and continue to make that path happen for people who want to be part of the future. Because I am going to retire someday soon, hopefully, and many are. And I think we need a whole new generation, and we got to get going now, because it takes 7 years to be a licensed clinical social worker in Wisconsin. So.
Won't let you retire.
Is that it?
No, there's a question.
Sorry.
I was just gonna ask about the community and family liaison and who the vendor was for that, and if they've been hired. And also, once in a while you refer to a Supreme Court case with Helen somebody. I'd like to know a little more about that so I can research that.
So Helen EF versus Fond du Lac County is a particular case. That case is more around people with dementia, I believe. That's
Okay.
The Lessard decision in Milwaukee is probably the first of the mental health cases. Tom Reed, you probably know these all off the top of your head. And there's Donaldson. Put me on the spot here. I don't have notes. There's a whole list of them that really have come to impact the law. The thing that people don't know, and I'll shut up because I know you want to get out of here. Case law is a big factor. So there's a nuance in Milwaukee County. A case was thrown out years ago because the person under emergency detention was not given access to their paperwork in what was described to be a timely fashion. So individuals have to be served the statement of emergency detention or the documentation. So a judge said it was not good enough. So today, it is a fact that we have to make sure that paperwork is in the hands of that individual within 40 minutes. And that literally came out of a series of court cases. No one said 40 minutes is the ideal period of time, but that is the threshold in Milwaukee County. So if we don't serve that person the paperwork within 40 minutes, that case gets thrown out. It'll be challenged by their defense attorney at court. So it's major decisions impact sort of the structure of the law, but the local sort of case law really structures how the reaction, so what we do, and then how it's experienced by our customers. So it's a really complex decision. I'm happy to send you some of I have documentation about a lot of this stuff. But it's not just one decision, it's like 20. So thank you again for being there again. Sorry, I think it's on me that I think my communication wasn't clear with Dr. Cole. I thought maybe he was spoken to independently and I didn't.
It might be a mutual crossing of paths.
I did my best, but he will come back and do the full on access clinic presentation someday soon. So.
Thank you, Mike.
The liaison.
Oh, I'm sorry. Yeah, MHA is the operator. Martina might still be online. I was told a couple weeks ago that we'd be moving forward in the coming weeks.
They
had a
hired,
person.
they hired a person.
So they did hire a person. They were super excited about, I believe they're trying to hire a certified peer to be part of that initiative. So we expect it to be going live very soon. We will do a very public press release. About it. We want to celebrate it. We were hoping to move forward sooner, but unfortunately there was some turnover, which is the theme in all of our services. But I know Martina was very excited about the candidate that they hired, and we expect it to be a good service.
MHA?
Mental Health America.
I did email them and they said they didn't know anything about it. So I must have emailed the wrong.
Mental Health America of Wisconsin versus Mental Health America probably would be so we can probably put you in touch with Martina. She was on earlier. I saw her ask a question. So that's the individual who I think she's still a steering committee member.
No, she's not.
We can make the connection.
Things are moving.
Absolutely.
Good.
All right, thank you, Mike.
Thank you.
We're gonna go to number 5 with announcements and closing, but I'm gonna talk about the 2 lines below because it's really exciting. Our next meeting for the month of May is Children's Mental Health Month, and we've got some really special events planned for that. And we really encourage the folks that tuned in online, if you can make it here, because we have some things that'll be physically happening here in the room. Not that you can't experience it, but it won't be as great. We're gonna have a panel of some young adults and youth that are gonna be presenting and some other exciting stuff. And then our June meeting conflicts with the meeting for the Milwaukee County Mental Health Board. And for those of you that don't know, I represent the task force on the Milwaukee County Mental Health Board. So we are moving the June meeting from here at Independence First to the Washington Park Senior Center, which is at 45th and Valete. And it's in Washington Park in the Senior Center. So we'll be meeting at our normal time of 3 to 5 p.m. And we're going to be inviting some other groups to our meeting, which include the Aging and Disability Resource Governing Board, the Council on Aging, and the who am I missing?
Your support.
Oh, no, hold on. The Combined Community Services Board, and we are going to be inviting the county board supervisors. And the first hour of the meeting is going to be really exciting because Mike talked about peer specialists. And Dr. Apple, Kristen Apple, they use peer specialists. I was involved with the initiative to start peer specialists here in Milwaukee that was started actually in Milwaukee County in 2002. And as it's evolved along Milwaukee and then at the state level, there are peer specialists that work behind the walls with folks in our correctional facilities. And they're referred to as forensic peer specialists. And it's time that we have forensic peer specialists for when people come out from behind the walls of the carceral system. And Dr. Apple has arranged for an amazing presentation that day. And that will be the only presentation that we have about having forensic peer specialists in the community. So it's going to be an amazing opportunity. And that will happen till 4 PM. And then at 4 PM, we'll have a meet and greet with the board members from the Milwaukee County Mental Health Board. And then at 4:30 will be the start of the Milwaukee County Mental Health Board budget session. At that session will be the release of the budget and what's being proposed in the 2025 budget. And people will be able to hear that. And the meeting will conclude at 5 PM. If you'd like to stay after 5 PM and hear the rest of the budget stuff. And that meeting that's public comment also, correct?
I believe so.
Yeah,
I don't remember.
I was trying to remember. I think people will be able to make public comment there as well. And so it's gonna be a really packed day. So people are encouraged to obviously attend in person. And there's an owl system that'll be used. It's a panoramic system that'll be used at the Washington Park Senior Center. So that's what's upcoming. And I thank you for listening to me. And now I'd like to bring Sally up because Sally,
Thanks.
yes, please.
That's part of it.
Sally.
Yes, Mary.
And we need to make an announcement.
Okay. Yeah, I just wanted to let everybody know this is my last week. It's been a privilege to work with all of you. There's just been a lot of, what's the word? Change, yeah, change and a lot going on after Barbara's departure. Hopefully some things will be worked out for my successor, thank you. But it's been really nice to get to know those of you that I've gotten to know, so thank you.
Thank you.
So see you.
I'd personally thank Sally for being a quick and tremendous learner and her commitment and all of the time above and beyond the time that she's been compensated for the work she's done in the months that she's been here and has dedicated to the Milwaukee Mental Health Task Force. And Sally has been quite the trooper and has made a major investment from her heart to get things going and keep things going. And I will miss you greatly. It's been really an honor and a privilege, and I'm kind of think we'll see you around. So I'd like to thank you from the bottom of my heart for everything you've done.
It's in the code, because we also just went through some, background.
Okay.
Sally, it's been a true privilege, working with you. You have been able to help streamline so many processes, especially with being able to click and join meetings. That has changed a lot, but you also been a big light encouragement. You're one of the most sincere people I've ever met. Thanks for likes on Facebook too. But most importantly, in your next journey in life, I hope that there's always a special place for the task force in your heart because the contributions you've made. I think to moving administration and just using that mental muscle, you are such a real. So I just want to say thank you very
much. I'm Nicole Lappen, for those of you who don't know, Montreal hired two of the newest coaches. But Sally, truly, we had kind of a whirlwind, let's get some bylaws put into place for the task force. And Sally would never written bylaws or did the research. She's pulled examples. She's been helping us write those. So she's been really resourceful. And as Mary in Montreal indicated, she has gone above and beyond the time that she has been compensated for. She shows a lot of heart. She contacts, she pops in the office here as we work a block away from each other. And, we go over problems. So she's seen my dedication. And
access to also mental health issues that are not. And we'll see you. You can always visit me a block away, but we really appreciate your dedication.
Yeah, and I just want to say thank you. Sally is one of the kindest people I've ever met. Genuine big heart, and it's just the thought of bringing cookies to our meeting every, and refreshments. I just want to thank you. It takes a lot of effort and coordination to get these meetings together. It may seem like we just call people and say, hey, you want to show up? But it's not, it's a lot more than that. So thank you for helping us through this transition period, and we're gonna miss you. Or hopefully we won't miss you because we'll see you, but thank you.
Pop in on us and see how we're doing.
Did you want to say something? Microphone.
No, I just said she'll pop in and see us.
Thank you.
Thank you.
Thank you very much. There's still probably some beverages out there. Are there cookies out there? Cookies and grapes, there's beverages and snacks. Please grab some, hang out for a few minutes. Say hi, say goodbye to Sally. Thank you, and we'll see you next month.